Hi, engineers. So in this video, we're going to talk about calcium channel blockers. Let's go ahead and get started. All right, so let's go ahead and get started on calcium channel blockers. The first thing that we have to talk about with these calcium channel blockers is their mechanism of action, right? And there's two different types of calcium channel blockers. One is a group called Non-dihydropyridine calcium channel blockers. What are the names of those two drugs? Well, one of them is called Verapamil. So it's called Verapamil. That is one of the non-dihydropyridine calcium channel blockers. So again, this group that we're going to talk about here are called your non-dihydropyridine calcium channel blockers. Okay? And it consists of Verapamil and another one called Diltiazem. All right, so how do these guys work and how are they different from the dihydropyridine calcium channel blockers? Well, the non-dihydropyridine work primarily on the heart, except for Diltiazem. Diltiazem has both the effect on the actual cardiac tissue as well on the vascular smooth muscle, just minor. It can also not just work on the heart tissue, but it also can work on the vascular system. Okay, that's important. So it can work on the heart and the vascular system, whereas Verapamil is primarily going to work on the cardiac tissue. Now, how do they work on the cardiac tissue? They act on particular components of the heart. You know, within the heart, you have two different types of cells, right? You have your intrinsic kind of conduction system, right? So that basically consists of like your SA node, which sends action potentials down to the AV node, which goes to your bundle of His. And the bundle of His sends things down into your bundle branches, and then it's going to go down into your Purkinje system. Well, that's all of your intrinsic conduction system. What they do is they work primarily by inhibiting the SA node, decreasing the heart rate. That's pretty cool. So one thing it can do is it can decrease heart rate by decreasing the action potentials generated by the SA node. But guess what else it can do? It can also block the AV node. What does the AV node do? It helps with conducting action potentials from the atria to the ventricles. If you block that, you're going to inhibit the AV conduction, which is very important when it comes to certain arrhythmias. All right, so it can block the SA node and it can block the AV node. So that's going to decrease heart rate via the SA node and decrease AV conduction via the AV node. But guess what else it can do? It can act on the myocardial cells that are contractile, not the pacemaker ones like these, on the contractile ones, the ones that have those myofilaments. And it can work by blocking the calcium entry into those cells, which induce contraction. So I'm going to inhibit contractility. So I'm going to decrease contractility. Ooh. That is pretty cool. We're going to go over the cellular activity of this in a second. Before we do that, going into how it affects the pacemaker cells and the non-pacemaker cells, let's go quickly talk about the dihydropyridine calcium channel blockers. So these are going to be your dihydropyridine calcium channel blockers. That's these little suckers, right? Now, what are some of these little guys? Okay, this is going to be things like Amlodipine. Amlodipine is a very commonly utilized dihydropyridine calcium channel blocker. Another one is called Nicardipine. Another one is called Nimodipine. And another one is called Nifedipine. So if you forget their names, just remember that it ends in that ipine, or actually we could say dipine. So it ends in that dipine component, right? So Amlodipine, Nicardipine, Nimodipine, Nifedipine. How do these guys work? They work on your peripheral vasculature, the arterial smooth muscle within the vessels. And it works to actually relax the smooth muscle within the tunica media, which controls the tone of those vessels. So if you inhibit constriction, what do you get? Dilation. So this is going to promote vasodilation. And that drop in that actual initiation of vasodilation can help with dropping two things. Total peripheral resistance, which is important for patients with high afterload. You don't want to increase the afterload, right? Because that can put more stress on the heart. And it also can decrease your overall pressure by decreasing the total peripheral resistance. So that's a beautiful thing about this drug, okay? or this drug class. Now, how do these drugs actually work on the cellular level? Here we got two cells. Here we have a pacemaker cell, which could be any one of these cells, let's say. Okay, and over here we're going to have a non-pacemaker cell. And as you can see here, it has that actin-myosin components. Okay, and these are going to be the contractile cells. And then here connecting the two, we're going to have just one gap junction. Just one good old cute little gap junction, right? How does this work? Well, you know you have these things called funny sodium channels. We're going to fly through this, right? And funny sodium channels allow for a little bit of sodium to leak into the cell. Very small amount, but enough to make the cell a little bit more positive. If we make the cell more positive, we're going to make the voltage, okay, less negative. So it's going to be a less negative millivoltage. As we cause the cell to become a little bit more positive, guess what that does? It activates this voltage-gated calcium channel. And this voltage-gated calcium channel is a T-type of voltage-gated calcium channel. And when he opens up, he's going to make the cell a little bit more positive. And so if we talk about it becoming more positive, it's going to be even more less, or we should actually say less negative millivoltage. We're going to start approaching positive voltage soon. As that happens, it activates this beautiful channel, this beautiful green channel here, called the L-type calcium channels. And when these open, they allow for calcium to blast into the cell and really make this cell super positive. And as that happens, it initiates what we call an action potential. And this action potential, we can propagate it to other pacemaker cells or non-pacemaker cells, right? We can push some cations into the other nearby cells. I have all these cations that I'm flushing into this non-pacemaker cell. What's that going to do? Well, it's going to make the inside of the cell positive, right? As we make the inside of the cell positive, it's less negative millivoltage. That's enough to activate these voltage-gated sodium channels that are on these non-pacemaker cells. And that allows for sodium to flush in very, very powerfully. And as sodium flushes into the cell, it really makes that cell super positive. And as that starts to happen, it starts causing an action potential to be carried down the sarcolemma and even down these little components called T-tubules and stimulates the sarcoplasmic reticulum. On the sarcoplasmic reticulum, we're going to have all these different types of L-type calcium channels. We're going to zoom into this. And what happens is it's going to, whenever the sodium crosses over this and depolarizes the membrane, it's just positive enough to stimulate the opening of these L-type calcium channels. Calcium rushes into the cell. As it rushes into the cell, what happens? It eventually activates the myosin, right? It binds to the tropomyosin, binds to the troponin, changes the shape of the tropomyosin, and allows for myosin to bind into the actin and induce contraction. So the overall result is muscle contraction. Now, follow with me. Ready? Calcium channel blockers, what do? They block the L-type calcium channels. If I block the L-type calcium channels, right, using my calcium channel blockers, calcium can't come in. There's less positive charge in the cell, and there is a decrease in the action potentials. That means less positive ions are getting shunted through gap junctions into pacemaker cells and non-pacemaker cells. That means that the cell isn't becoming less negative. It's not going to stimulate the voltage-gated sodium channels as well, and there's going to be less sodium coming into the cell. Less sodium coming into the cell means less positive charge in the cell. That's not going to generate that action potential. So that's going to result in decreased influx of calcium. If there's a decreased influx of calcium through the L-type calcium channels, in addition, these bind also on that point and even make this pathway even more dropped. We're going to have even more low calcium levels. That's going to result in less of this cross-bridge interaction and decreased muscle contraction. So we can decrease action potentials through SA node and AV node and inhibit contractility. Oh, so cool. The concept is the exact same in the vascular smooth muscle. Here we have these L-type calcium channels, and calcium flows into this actual smooth muscle cell. So this is a smooth, these were cardiac, this is a smooth muscle cell of the tunica media within the vessels. That's in the vasculature. Calcium flushes in. When calcium flushes into the cell, when it's depolarized, okay, then what happens? Then calcium binds onto a protein called calmodulin. And then calmodulin can activate this thing called CAM kinase. And CAM kinase can convert what's called myosin light chain kinase into a phosphorylated myosin light chain kinase, which then can phosphorylate the heads of myosin. When you phosphorylate the heads of myosin, it creates such a way that it allows for that cross bridge formation to occur. And what happens? Muscle contraction. So as a result of that, you get muscle contraction. Now, follow with me. We're going to use calcium channel blockers. We're going to inhibit calcium entry. Less calcium comes into the cell, less calmodulin activation, less CAM kinase, less phosphorylated myosin light chain kinase, and less phosphorylation of the myosin heads. Therefore, there is a decrease in muscle contraction. It's such a beautiful mechanism. That's the mechanism of action of these drugs. Let's get into the indications. All right, so let's get started on the indications. Why do we use these drugs? What's the purpose of them? What does it do? Remember we said the big thing is it drops the heart rate and it drops the AV conduction pathway, right? So it decreases that. What would that be good in? What kind of thing would we want to maybe slow down someone's heart rate? What if they have AFib and they have multiple reentrant circuits or multiple ectopic foci that are sending these action potentials through that AV node? What if we block it and we give it time to reset? That'd be pretty helpful, right? So if someone has atrial fibrillation, or if they have another condition where maybe they don't have multiple ectopic foci, but they have what's called a cavo-tricuspid isthmus, which is basically here around that tricuspid valve, and it can generate reentrant circuits, which is very common in atrial flutter. We could also use this in atrial flutter. In other words, this is great for supraventricular tachycardias. What's another one that can actually also kind of alter some of the activities that are kind of generated in the atria and have to go through the AV node? What if someone throws a lot of PACs? Oh. And it becomes to the point where they're actually symptomatic. Let's actually write this out for you guys. Called premature atrial contractions. Okay, so we call these PACs. That's how they're abbreviated, right? If you're throwing tons and tons and tons of PACs, then you might start becoming symptomatic. We could use calcium channel blockers in this sense. But generally, if someone has PACs, we don't necessarily have to give them medication. They might just be able to deal with it, and they might be asymptomatic. All right, that's some of the things we can do. So we can help with this process here. Good thing for arrhythmias. What about decreasing that contractility? Let's go back to that effect. If we decrease contractility, what kind of situations would that be good for? Remember, here's something you gotta think about. If you decrease contractility, it does two things. It decreases cardiac output and decreases blood pressure. But it also does something else. It decreases oxygen demand. So this would be good if I decrease oxygen demand because I'm not consuming as much oxygen now because I'm not contracting all the time. What would that be good for? Maybe someone who has angina pectoris, but we got to be very careful because some of you guys might realize we don't commonly use this for angina pectoris, and it's not for acute coronary syndrome. So we got to make sure that we specify this is not for ACS. It's for someone who maybe has stable angina and they can't tolerate a beta blocker. What will we go to if they can't tolerate a beta blocker? We might try a calcium channel blocker. Another one that's commonly utilized, because we can't give beta blockers in these patients, is Prinzmetal's or vasospastic angina. Okay? This one you can't give beta blockers to. So if you can't give beta blockers to them, what's another drug that could help you with this? Calcium channel blockers. It drops blood pressure. What kind of conditions would that be helpful in? Hypertension. So if someone has hypertension. Now, it's actually really important for us to remember that this can be used not just in hypertension, but also in patients with hypertensive emergencies. What is that? Whenever somebody has a blood pressure greater than 180/120 and they have end organ damage, that would be another drug that we could give, particularly like Nifedipine. Okay? or even Nifedipine. There's a lot of them. And then the other thing is it's also good in pregnancy. So you can use this in patients who are hypertensive, and they're pregnant. Nifedipine is actually a very common one. Okay. All right, so what else does this do? What does this, remember whenever we use like things like dihydropyridine, calcium channel blockers, what do we say it can do? It can cause vasodilation. And what does that do? Well, it does one thing, right, which is going to be it drops blood pressure. Another effect is it actually decreases afterload. So it reduces afterload. Okay, so we can use this to help to reduce afterload, which reduces the stress on the heart. So what would this be good for? Okay, it could actually be good for someone if we want to drop blood pressure. What if they have hypertension? So this could be good in hypertension. Here's something else that we can do. You know, there's a condition where certain patients who maybe have an underlying condition like scleroderma, right? There's what's called CREST syndrome, where you can have calcinosis, Raynaud's phenomenon, esophageal dysmotility. You can have sclerodactyly and telangiectasia. It's a type of scleroderma, which is kind of an autoimmune disease. In those situations, patients might go out into cold temperatures. And whenever they go into these cold temperatures, the vessels in their distal, in the digits, they undergo intense vasoconstriction and decrease the blood flow to those distal phalanges. And they turn white. Then over time, as they start to respond, they go blue, and then eventually they go back to red, or to the normal skin hue. What if we could use drugs that could reduce that vasospasm in cold temperatures in patients with Raynaud's phenomenon? What would that be? Vasodilation mechanisms, right? That'd be good for calcium channel blockers, which would be good for Raynaud's phenomenon. All right, cool. Now, another thing. You know when patients have subarachnoid hemorrhages? Whenever they have subarachnoid hemorrhages, what's important to know about this is that this can promote spasming of the vessels that are going to be supplying that area of the brain. So there can be vasospasm. So there can be vasospasms whenever someone has potentially maybe a subarachnoid hemorrhage. So whenever someone has a subarachnoid hemorrhage, this can promote vasospasm of the nearby vessels. What can we do if it's spasming and contracting? Give a vasodilator, a calcium channel blocker, to reduce those vasospasms. So this would be good in helping to reduce vasospasm in subarachnoid hemorrhage patients. Pretty cool, right? And also on top of that, we can control their blood pressure. We don't want to drop their blood pressure too much, but we don't want to continue to keep allowing for more hemorrhage to occur. So it can help to control the BP and reduce vasospasms. Okay, now the next thing that's really interesting is that there's some drugs that actually, some of these calcium channel blockers could potentially be used in patients who have cluster headaches. So cluster headaches are basically described as this stabbing, lancinating pain that you can sometimes feel behind the eye. And it's usually unilateral. They also could have rhinorrhea. They could potentially have nasal congestion. They could even have what's called Horner syndrome, which is when they might have ptosis. They might have facial anhidrosis, as well as the meiosis of the actual pupil. And so sometimes we can use calcium channel blockers in the treatment of cluster headaches. So they could be used not in the initial setting, because usually initially when someone has a cluster headache, the best thing to do is to give high flow oxygen, 10 to 12 liters. But usually if you want to try to prevent these recurrences, there's a potential of using calcium channel blockers for patients who have cluster headaches. Okay? Last thing here. Remember, calcium is also not just important in vascular smooth muscle, it's also important within the smooth muscle of the GIT. And they can inhibit calcium entry into those actual smooth muscle cells, which can initially cause relaxation, okay, of particular points of the GIT. Well, you know there's a condition called achalasia. So it's called achalasia. And basically what happens with achalasia in this situation, what we're worried about, is right at what's called the lower esophageal sphincter, right? Your lower esophageal sphincter, it's super tight, okay? Let's use that word, tight. In other words, it doesn't want to relax. If we could potentially give a drug that could relax that lower esophageal sphincter, what could we then do? We could allow for the food bolus, which is in our esophagus, to enter into the stomach. So then we could actually help to move this thing into the stomach. Because some of the symptoms, particularly of achalasia, is they could have potentially regurgitation. They could have halitosis. They could have dysphagia. Okay? So if we can relax that actual lower esophageal sphincter, we could potentially allow for the food to go from the esophagus and nicely into the stomach. Unfortunately, it's not the best for achalasia, but it's something that we can do to potentially help them. All right, so now let's go ahead and talk about potential side effects or adverse drug reactions that could potentially happen if you're on a calcium channel blocker. Because yes, you should know how they work. You should know the names of them. You should know what they're used for. But you should also know what's something that I have to watch out for if I put someone on this medication. One of the potential things here is you got to go back to the overall mechanism of action, right? What does it do to the heart? That can drop the heart rate a decent amount. And what happens if you drop the heart rate? That could potentially maybe lead to severe bradycardia, potentially even a heart block. What can heart blocks do? They can decrease perfusion to potentially the brain. What could that lead to? Syncope. Okay, so that's something we have to be careful of. Another thing is, remember, you reduce contractility. So maybe if you give too much of this drug or you give it to someone who has already maybe potentially a weak heart, or maybe even like aortic stenosis or something like that, then you can reduce their contractility, right? This generally reduces contractility. But if maybe you give too much of it or they're a little bit more sensitive, what does that do? Well, that drops their cardiac output. If you drop someone's cardiac output, right, so you reduce contractility, reduce cardiac output, then that can potentially reduce their blood pressure. And what does that do? If you reduce cardiac output, you can reduce blood pressure, and this can be leading to hypotension. So a potential side effect is bradycardia, potentially heart block, as well as hypotension. All right, it's acting on the peripheral vasculature, right? And again, what does it do to the peripheral vasculature? It relaxes the vascular smooth muscle, right? So with you causing vasodilation, what can that do? Well, here, let's think about this. Vasodilation can drop blood pressure. You know what happens when you drop blood pressure? Remember, you stimulate these specific sinuses. You know, within the aorta, you have the carotid sinus, and you also have what's called the aortic sinus at the aortic arch. What do? They send action potentials to your central nervous system and activate your cardiac acceleratory center. What does that do? It increases your sympathetic nervous system activity, which leads to an increase in heart rate. What is that called? If you give this drug, it vasodilates and then leads to them having a reflex tachycardia. That's a potential symptom. So reflex tachycardia. Also, you're vasodilating, you're dropping blood pressure. What's a potential effect of this? There's a potential of hypotension. Next thing, there's also something you have to watch out for is that when you give this drug, right, not only can it cause reflex tachycardia and hypotension, but with vasodilation, there's a risk of increased capillary permeability. And this can lead to increased fluid in the interstitial space. And what is that called whenever you have a lot of fluid in the interstitial space? Edema. And this commonly occurs in the peripheral lower extremities. So there's also the risk of peripheral edema. The other thing that you have to remember is if you vasodilate certain blood vessels that are close to the skin, so if these vessels dilate and they're close to the skin, what can that make it look like, or what can it make it feel like if those vessels dilate on the skin? It can feel like you're flushing, right? So it can have this sensation of flushing. So that is another potential side effect of being on these dihydropyridine calcium channel blockers. So this is for dihydropyridine calcium channel blockers, whereas the effect on the heart is primarily by non-dihydropyridine calcium channel blockers. So again, another potential side effect is flushing because of vasodilation of the vessels close to the skin. And not only do you have to worry about hypotension in general, but you should also worry about orthostatic hypotension, right? Which is basically whenever you come from maybe a seated to a standing position and the blood doesn't return to the heart enough, you don't get enough blood volume in the heart to pump to the brain, and you start to get dizzy, presyncopal, and potentially pass out. So that's something else you want to watch out for. All right, next one. Super weird one, but they love to ask this on the exams, and they don't really know why this happens, but calcium channel blockers have the potential to cause thickening of the gingiva. They make it thick, right? So what is that called if you thicken up that gingiva? That's called gingival hyperplasia. So they increase the production of the epithelial tissue of the gingiva, and this is called gingival hyperplasia. And surprising enough, the most common one that causes this is amlodipine. So they see it most common in amlodipine. All right. Now, let's go back to this now. Remember what we did on the actual smooth muscle of the GIT? What could it potentially do to the smooth muscle of the GIT? For achalasia, relax that lower esophageal sphincter. But what if you relax the smooth muscle that's helping to propel food contents or feces towards the rectum? Decrease GI motility. If you decrease GI motility, that gut ain't gonna work, right? And because of that, it can potentially lead to constipation, right? And nobody wants that. All right, so this last side effect, or ADR, that we have to watch out for with calcium channel blockers, actually more particularly is with one of the calcium channel blockers called Verapamil, right? And if you guys remember, Verapamil was one of those non-dihydropyridine calcium channel blockers. This side effect is a little odd, but it's something I wanted to mention because it could come up on an exam. If you guys go back to a little bit of your endocrinology, you have the hypothalamus, right? Which is a kind of a piece of gray matter located within what's called your diencephalon. And in the hypothalamus, you have these particular neurons, these dopamine-producing neurons, right? So here's my dopamine-producing neurons. What happens is these axons come all the way down and they secrete a specific type of hormone called dopamine. And that dopamine acts particularly on this lactotroph, right? Which is the cell that produces prolactin. Let's zoom in and take a look at how Verapamil affects this. Before we do that though, you guys remember that dopamine, right? Dopamine does what? It actually acts on these lactotrophs and inhibits prolactin production. So now dopamine inhibits these actual lactotrophs, right? And if you inhibit the lactotrophs, now they're not going to release prolactin. All right, so there's going to be a decrease in prolactin production, generally, whenever there's dopamine. Okay, so whenever there's normal dopamine production, this dopamine is going to inhibit prolactin production by the lactotrophs. Now, take into consideration Verapamil. Verapamil actually works by inhibiting dopamine release. If you inhibit dopamine release, that's going to be decreased dopamine in the synapses. Now you have less inhibition on the lactotrophs. And if there's less inhibition, there's going to be stimulation of these lactotrophs. And now the prolactin production will start to increase. What do we call this whenever someone has elevated prolactin levels? It's called hyperprolactinemia. All right. I think I spelt that right. Hyperprolactinemia. Now, that can produce different types of clinical manifestations in the different sexes, right? So for example, in the male, it can cause enlargement or accumulation more of the actual male breast tissue, okay? And that's called gynecomastia. So gynecomastia, all right? That's moobs, all right? That's moobs. The other one is going to be in females. It can actually cause milk production, okay? Increased milk production, and that could potentially lead to galactorrhea. On top of that, it also can affect the normal FSH and LH activity as well as estrogen levels, and that could potentially lead to certain types of menstrual irregularities. Okay? So that's something that you need to be aware of with Verapamil, is that it can potentially produce hyperprolactinemia, causing gynecomastia in males, galactorrhea, and menstrual irregularities in female. Okay, so what are some of these things that we have to watch out for? Remember, what does it do to the AV node? It blocks that AV node, right? So it decreases AV node conduction. And on top of that, it also drops your heart rate as well, right? So there's the combo of dropping the heart rate by decreasing the impulses generated by the SA node and blocking that AV node. If we block that AV node in a particular condition called Wolff-Parkinson-White Syndrome, that is potentially dangerous. Why? Wolff-Parkinson-White Syndrome has this accessory pathway called the bundle of Kent, which is this accessory pathway which is able to conduct electrical potentials just like the AV node. But what did you do with giving the calcium channel blocker? Maybe too much of it. You inhibited the AV node conduction. Now the electrical potentials only have one way to go through, and that is the bundle of Kent. The risk of that is that that can lead to potentially VTAC or VFib. That is why this is dangerous. You do not want to give this drug to patients with Wolff-Parkinson's-White syndrome. Plus, it can even be worse if they have a corresponding AFib. That's actually 1-to-1. Okay? The other thing is you're inhibiting the AV node, right? What if you give another drug that also inhibits that AV node even more? That's a problem. So another thing that you do not want to give this with is also if someone is on a beta blocker. Okay? So you do not give this if they're on a beta blocker. You don't want to combine those two. The last thing is if you decrease the action potentials or you decrease the conduction from the atria to the ventricles, are you going to have a proper connection between the atria and the ventricle now? No. What's that called whenever you either have partial interaction or complete loss of interaction between the atria and the ventricles? That's called a heart block. So another potential contraindication that you want to watch out for in this is heart block. You don't want to give this to a patient who has a heart block, maybe second, maybe third degree, because you potentially could block that heart, block the AV conduction, and make their heart block even worse, potentially causing them to become syncopal. All right? Last thing here. It also can reduce contractility of the heart, right? So if you reduce contractility, what do we say that does? Remember we said that it can cause two things. Drop your cardiac output and drop your blood pressure, but it also decreases oxygen demand. Well, here's the situation where you got to be careful. What if somebody already has a weak, damaged heart? Like what? Someone has congestive heart failure, particularly someone has maybe decompensated heart failure. Maybe they have decompensated heart failure or just in general, a really weak heart. Okay, decompensated heart failure. Are you going to want to give this drug to someone who has a really weak heart as it is? No, that can make it much worse, right? Because you're technically inhibiting the inotropic activity with an already presently weak heart. What if you have something where the aortic valve is super stenotic? And normally, if someone has aortic stenosis, what's the problem with aortic stenosis? You're getting less blood flow across that aortic valve into the actual aorta. And where does the aorta deliver blood to? To the brain, right? If you have aortic stenosis, which is reducing blood flow to the brain, what is that going to result in? Potentially syncope. And you're also not getting enough blood flow going through the coronary vessels. So there could also be decreased blood flow through the coronary arteries, which could potentially lead to angina. That's a problem. So if you decrease the contractility, what are you going to do? You're going to drop the blood flow even more, which is going to exacerbate syncope and exacerbate blood flow to the coronary system, which can lead to potentially a myocardial infarction. And the last thing that we also want to be careful of this with is someone who's already hypotensive. If they're hypotensive, you give them this drug, what are you going to do even more? You're going to drop their blood pressure even more. And that's not something that we want, okay? Last but not least, something you have to remember. If you give someone a calcium channel blocker, you better know how to reverse it if you need to. So what is the antidote, we can kind of say, if someone is on a calcium channel blocker? The antidote that you should remember is very simple. You're giving a calcium channel blocker. That's blocking calcium entry, right? In a kind of a competitive way. What happens if you increase the substrate concentration in a biochemical reaction? You could potentially knock that competitive inhibitor out of that actual binding site. So if I give them more calcium, I could potentially knock that calcium channel blocker off and allow for calcium to get into those cells. So what do I got to give them? Give them a lot of calcium. So the antidote is actually pretty simple. You can give them calcium in the form of either calcium gluconate or calcium chloride. All right, so that's something to remember with respect to calcium channel blockers.